Hello, I'm introducing our next presentation. Good morning, my name is Dana DeHerrera-Smith with Front Range Clinic, and our next presentation offers best practices for medications for addiction treatment and mobile health services. All three of our speakers play a crucial role at Front Range Clinic, which is a low barrier, high access network of outpatient addiction treatment clinics. Dr. Jeremy Dubin is the FRC Medical Director, who's been board certified in addiction medicine since 2006. He lectures and teaches locally, nationally, and internationally in the field of addiction medicine. He is an assistant clinical professor at the University of Colorado School of Medicine in the Department of Family Medicine and clinical faculty adjunct of Rocky Vista College of Osteopathic Medicine. He is committed to teaching and precepting medical students, residents, and helping to direct the 35 medical providers at Front Range Clinic while challenging stigmas through education on an ongoing basis. Donna Goldstrom is the clinical director and mobile health coordinator and maintains all of the OBH licensure for all behavioral health programming at Front Range Clinic. She is currently a licensed professional counselor and a licensed addiction counselor with the state of Colorado. Donna has worked in a variety of settings, including residential, outpatient, private practice, and medical clinics for the last 20 years. And then we have, last but not least, Kathleen Crislip, a nurse practitioner specializing in substance use disorder treatment and is the medical lead and the mobile health unit supervisor for the Western region. Kathleen has long been involved in local community service in her mountain town of Steamboat Springs, Colorado, and is working on integrating and supporting effective evidence-based substance use disorder treatment care in Colorado's remote communities. Thank you.
Okay, hi everybody. Well, welcome to our talk. We're going to have actually three 15-minute slots where I'm going to kind of fly up to 30,000 feet and discuss addiction kind of 101, just to make sure that we're kind of all at the same bar. I think for a lot of folks, that'll just be a little bit of a reinforcement and a reminder. And then we're going to jump into a little bit about some of the medications that are being used for MAT, or medications for addiction treatment. And then I'm going to turn it over to Donna and Kathleen, so they can talk about the exciting work we're doing around the state on the Western Slope when it comes to our mobile health units and some grants. So next slide, please. So I want to just step back for a second, and I want to discuss about before we kind of dive in, let's back up for a second. We talked a lot about today about substance use disorders. We talked a lot today about folks that are vulnerable to that. And it's pretty tough following Dr. Barnes. That was a fantastic lecture, and I can't wait to kind of watch that again and take better notes. It was excellent, and I definitely will take you up on getting those slides. But I want to step back for a second, and I want to challenge kind of all of our thoughts for a second about why people use drugs and alcohol. Because often when we talk about drugs and alcohol, we discuss them in context of addiction. In other words, it's kind of black or white, negative or positive, good or bad. And it's really easy for that moral barometer to kind of come into play. So I want to step back for a second. We've been using drugs and alcohol for thousands of years. Ayahuasca root, coca leaf down in South America, marijuana, Rastafarian cultures, wine and Judeo-Christian cultures. So we use it for all sorts of different stuff, to alter our moods, religion, explore the self, escape boredom, promote sexual interactions, enhance sensory experience. Next slide, please. But often people will use drugs and alcohol because they work, because they help them, because they actually remedy their short-circuited reward system. And we're going to speak a little bit about that. And you've heard a little bit about this today, and I think many of you already know this, but the idea that what I think Dr. Barnes was speaking to, and also Dr. Valek before him, was that whether it's you're vulnerable to this from the beginning, or this happens to you environmentally, or both, it changes your brain. Next slide, please. So I'm going to talk about opioids in specific because we are talking about MAT, or medications for addiction treatment. And like I said, I'm not going to jump into getting into the details of these too much because I really want to turn this over to Don and Kathleen to discuss what we're doing to help folks. But as you can see here, things have been increasing since even the late 90s. And any opioid has been increasing. Synthetic opioids have been overtaking heroin lately, and those are your Percocets, your Oxycontins, your hydrocodone, fentanyl, things along those lines. But opioids are opioids. And after you get them into your system and you've been using them for a while, your brain doesn't really know much of a difference between heroin and I took too much Percocet over a couple months. Next slide, please. So as we said, drug addiction is a complex illness. Next slide. And the question comes up often, is it a disease? Well, let's back up for a second, because I think we get stuck on that word, because that word has a lot of negative connotation to it. In other words, Well, there's nothing you could do to prevent it. It was a disease. Well, there are pieces that are related to things like diabetes. For instance, you can acquire diabetes in your life because you might be vulnerably or genetically vulnerable to it. You could have been born with having to get insulin, the need for insulin. Same idea. Some folks are kindled more vulnerable to this than others, but what we do know is looking at PET scans is that there are objective changes that occur in the brain after long-term drug abuse. We see, that's how we diagnose disease, objective changes. When we diagnose somebody with diabetes, we look to see if they're making insulin. We look at objective findings on imaging and in labs. Same thing with this, and we've seen that. We've also seen this be expressed in twin studies. So in other words, twins that have been separated. And we've seen this with hypertension, with diabetes, but then you get twins back together that haven't been together for 20 years and you find out that they both had problems with nicotine or alcohol or opioids. Pretty interesting when it comes to that. Also, it has a lot in common with chronic relapsing conditions, such as diabetes. We don't necessarily have a cure. We have tools to help people live a long, functional life. And that's kind of where we're going to get to with the mat. Next slide, please. So we've known for a really long time that this is a chronic medical illness. And it's hard to put our heads around this. I get it. We don't have great tests to say, well, you suffer from addiction and you just suffer from wanting to drink a little too much once in a while with your buddies on Saturday. I mean, it's not easy to figure out where people lie on this continuum between drug use, maybe even drug dependence, and addiction or problem use. But we've known now for 20 years, this is from JAMA in 2000, we've known for 20 years that objective findings on brain imaging are real. That people that have drug addiction or substance use disorders most probably have actual objective changes in their brain. So just like when, if any folks from the 80s on this call will remember the whole commercial about this is your brain on drugs. Well, your brain does get affected by continual drug use. It does change, it adapts. And when you pull the drugs away, you are left with a brain that is thirsty, that is going to need to survive. And this is why we have folks that are leaving their kids in the car to go knock over 7-Elevens and pharmacies so they can get their Percocet. It's not because they want always to commit crime or lie or mess up their relationships. There is a survival instinctive need to survive. And that is what chronic drug addiction does to the brain. Next slide, please. This is from Robert Downey Jr. It's like I got a shotgun in my mouth with my finger on the trigger and I like the taste of gunmetal. Next slide, please. So how did we get here? Well, we got here, there are a lot of different ways we got here, and I like to think that we're going to crest on these opioids after a while, just like we've done what we did with crack cocaine in the 80s, and we're going to keep doing the good work that we've been doing to try to get on top of this. But there was a perfect storm. We were told in the 90s, and I was part of this, that we were under-treating pain. And we were told that we had to treat more pain. In fact, it was called a fifth vital sign in the emergency rooms. If you were under-treating someone's pain, you could actually be disciplined. We found that there were more potent opioids available. That made folks that were vulnerable to this and their brains primed for this victims at times. There was misunderstanding about the brain changes that we just discussed. Often people still think about this as just a moral decision. And this really permeates even the medical community today. There's a big stigma out there. In other words, when folks said that you were depressed in the 80s and the 90s, it was kind of like we kind of got to this conclusion like, whoa, depression is pretty prevalent. My uncle's depressed, maybe my sister, maybe I'm depressed. How you doing? You getting some help? You getting some medicine? You getting some therapy? We haven't gotten there yet with addiction. We are getting there with that loss of stigma. We are getting closer. We are better than we were 10 years ago. We're better than we were 20 years ago, but we still have work to do. There's also a lack of faith that treatment works. I remember when I was training, I had attending physicians that used to say to me, well, you know, not much really works anyway, so what are you going to do? So when that permeates the medical community, it's easy to kind of lose hope. It's also been a fragmented medical system, and some of the things that Dr. Valak was talking about this morning is going to be instrumental in helping to solve that. There's also been low screening when people were prescribing opioids. As a family doc, I was guilty of this as well. When we didn't have the tools, we weren't taught this at the beginning. And so this understanding is evolving over time. Next slide, please. So the life of somebody that is in an active opiate addiction sounds pretty terrible. What they're doing is that this is a very old slide from some of the methadone studies. And this is from the 60s. And this slide kind of shows what the life of someone that has opioid use disorder actively is going through. They basically go from sick to being stoned, sick to being stoned. And then the drag of it for them is they're not even getting high anymore. After a little bit of time or some time, they go from sick to normal, sick to normal. So this is their daily life. Next slide, please. The goal of medications for assisted treatment, or at least for some of them, including methadone and buprenorphine, is to try to create a leveling of the playing field, of trying to create that biochemical intervention so that you can level that up and down between being sick, being high, being sick, being high, so that folks can ideally have a sense of normalcy biochemically. And what this can do ideally is set the stage for folks to do the real hard work of healing that Dr. Barnes was discussing, the psychological work, the social work, the emotional work, sometimes the psychiatric work, the non-opiate pain work, the important trauma work, so that they can not only level the playing field, but they can get the tools under their belt so they can have successful recovery. The medications aren't necessarily treatment, they help level the playing field, and they have brought our statistics from around 10, 20% of recovery up into the 40, 50, 60%, which is been lifesavers. Next slide, please. So there's a few medicines out there. There's methadone, buprenorphine, and naltrexone we use for opioids. We also use naltrexone for alcohol use disorder. Methadone is a medicine you can only get in a state and federal clinic. Buprenorphine and naltrexone are medicines that we use at Front Range Clinic, and we use them outpatient, and we're going to talk a little bit about what these mobile units are doing. But what these medications do is they offer folks the opportunity for some sort of biochemical stabilization. So like I said before, so they can engage in the important work of healing that needs to happen in treatment. These medications are tools. Next slide, please. So as you see here, there are many components of comprehensive drug addiction treatment, and as our next speaker, Donna, likes to say to me, I'm a frustrated counselor. I wish I had the skills that she has and Dr. Barnes, and I just pretend to be one on TV here. But as you can see here under this, pharmacotherapy underneath treatment plan is just one piece of the puzzle, one spoke on this big wheel. In fact, the medicines often play an ancillary role, sometimes an early role to set the stage so that Dr. Barnes and Donna can do the hard work with folks. And as you can see here, this spans all the way from child care services to vocational training to family therapy to regular old counseling. Next slide, please. So how do we get out of this? How do we get out of this? Grants like these that we're going to talk about, symposiums like these, collaborating together so that we can discuss these things and have consensus. I am honored to be with these speakers today and everyone that's put on Supar. I can't wait to get in touch with Dr. Barnes and Dr. Valek. They don't know I'm coming, but I'm coming. I want to talk to you guys. We need better screening for vulnerable individuals, folks in primary care, pediatricians, so that we can help folks that, you know, the same way we tell people you might be vulnerable to diabetes. You got to watch what you eat. You got to exercise. Same thing. We have to challenge the stigma so that we can be able to talk to folks earlier on in their lives. And this is all the way from primary care to community, to teachers, to police, where we can actually get in there and say, you know, you might be kindled. You might be vulnerable to this. Let's make sure this doesn't happen for you, and to remove the stigma of it. Another way we can get out of this is increased access to treatment, and especially after detox or incarceration. And you've heard that a few times in this talk already. We also need increased caution when it comes to opioid prescribing, and a general understanding that there are brain changes that occur. It doesn't remove people's accountability or responsibility. Just like if someone had diabetes and wasn't doing well, and it was affecting their relationships and their lives, they have a responsibility to try to take care of themselves if they want to maintain their health and their relationships. It's the same idea, but to understand it as having biochemical roots is, in some cases, I think is very important. Next slide, please. So the point being is that people do get better. I wouldn't do this for as long as I've been doing it if I didn't see people get better. It takes a team. It takes a community like this. Medicine, like I said, is one piece of the puzzle. Medicine sets the stage so folks can engage in important healing modalities. Next slide. And I'm going to bring this on to Donna right now. And thanks for your listening, and we'll answer some questions at the end.
All right, thank you, Dr. Dubin. That was an awesome 101 about education and the opioid epidemic. And thank you to everyone at Supar who is putting this on, to Matt and everyone. This is such an odd time to do conferences, right, over the computer like this. So I just really appreciate everyone's hard work to get this done. So I am the clinical director for Front Range Clinic. I manage all the behavioral health components as well as the mobile units, as Dana said. And we were lucky enough to be the recipient of a grant from the Office of Behavioral Health that came down through SAMHSA, through the federal agency for mental health and substance abuse, money specifically designed for the opioid epidemic. And we are going to spend most of our time today talking about opioids, but I do want to make it clear from the get-go that we recognize that opioids are not the entire problem, as Dr. Dubin said. Especially in our rural communities, there's lots of other substances that are problems as well. So SAMHSA created this grant down through the Office of Behavioral Health to build and provide 6 mobile units throughout the state of Colorado, divided up the state into 6 regions. And Front Range Clinic was lucky enough to be awarded 4 of those 6 regions. So we manage 4 of the mobile health units out of our Pueblo, Colorado Springs, Greeley, and Grand Junction brick and mortar clinics. Next slide, please. In the beginning, before we had the mobile units, while the state was busy building them, they're very specialty built units, we began, after we got the grant, we began our outreach into these rural communities. And it bears saying here as well that these communities were chosen by the state of Colorado as having high rates of overdose and low access to treatment. So they were not just randomly chosen. There were risk assessments given in these communities and data looked at and picked each community. We'll go into what those communities are in just a second. So we started our outreach to these communities, building relationships with the folks who are there, and as well as finding a place for our mobile unit to park, the logistics of the situation. And we hit the communities on medical, behavioral health, law enforcement, support services like food banks, homeless shelters, government agencies, and as well as pharmacies. We have very close relationships to the pharmacies because we do carry no narcotics on the mobile unit. So we write prescriptions for the buprenorphine products like Dr. Dubin was talking about. Next slide. Thank you. And Kathleen is going to mention a little bit more about this, but we've also kind of added an SUV component to the mobile health units. You saw pictures of that RV, and you all live in Colorado. You know that it may be difficult to get that thing up some of our mountain passes, and it has proven so. Kathleen's going to talk a little bit more about that. But so in some of the regions of the state, we take an SUV, a Highlander, up to the more difficult areas to get to, and we take the mobile health unit out to a little bit easier terrain. Next slide, please. So these are our mobile units. So we'll start up here in the Northeast, out of our Greeley clinic, we go to Sterling, Julesburg, Sedgwick, Fort Morgan. And the mobile unit goes out there every single week, runs the same routes. So for example, on Monday, we go to Julesburg and Sedgwick. On Tuesday, we go to Sterling. On Wednesday, we go to Fort Morgan. And then we repeat that route every week. So we're there every week at the same time. People start to know when we're coming, and we run like that. In where you guys are, the Steamboat region in the Northwest, we have pop-up clinics. We utilize that SUV, and Kathleen will talk more about this, to go to Oak Creek, Walden, Granby, Fraser, and what am I missing? Hayden. And then also more on the Western Slope out of our Grand Junction clinic, which we just got started this week. We saw our first patient in Delta this week. We go to Montrose, Delta, Glenwood Springs, Eagle, and Rifle. And then down in the Arkansas Valley, out of our Colorado Springs clinic, we go up to Fairplay, Bailey, Canyon City, West Cliff, and Buena Vista. We also go out east to Lyman and Burlington out there on the I-70 corridor. And then down in the southeast, out of our Pueblo clinic, we go to La Junta, Los Animas, all the way down to Springfield, Trinidad, and Wilsonburg. Next slide, please. So on the mobile unit, here are some pictures of the inside of the mobile unit, and this is my Greeley mobile unit staff. We have 3 people, 2 to 3 people. In the front here is Nikki, she's our counselor. Behind her is Christy, our nurse, and sitting in the passenger seat is Tanya, our peer specialist. So on the mobile unit is a front desk area and a waiting room area, a small counseling room, a bathroom to do UAs in, as well as an exam room. And we're going to talk about this a little bit later on as well. But, you know, when we first got these units, we started running in December of 2019. We first got our first unit in October of 2019. We're like, wow, they're huge. You know, we got to learn how to drive them. We got to walk around in them. These units are giant. They're so big. And then COVID hit in March, and all of a sudden, these units became quite small when trying to maintain 6 feet between people in them. So it's just interesting perspective changes with that. But that's kind of the layout of the unit. Next slide, please. So our pop-up clinic model that we utilize with our SUVs is something that Front Range Clinic has been doing well before the mobile unit project, where we literally drive a vehicle and an admin staff or a peer out, and we use somebody's office. All we need is a private office and access to a bathroom. And through telehealth, we can access our medical providers and provide treatment to folks in lots of different locations. So we've been doing this. We've got 11 different locations all over Fort Collins, Denver, down to Pueblo, and out to Grand Junction, where we do this pop-up clinic model, utilizing someone else's space for just a few hours once a week. Next slide, please. So the services provided in the mobile health unit project. We do telehealth for the medical as well as the counseling. It didn't start that way for counseling, but due to COVID, we've brought the counselors into our brick and mortar clinics to provide telehealth counseling on the mobile unit. And we also have peer support. And this is just so crucial to the entire project, as you know, and you heard the personal lived experience in the very beginning of this conference today, that peer support is so crucial. Our peers are really there to be the vision of somebody who has accomplished recovery. You know, the goal of the mobile units is to reach out and find those people who have not accessed services before, either because they were afraid, they didn't know services were there, or services were not actually there. And so the idea is that the peer can talk to those people and say, this is hard. This is going to be hard, but you can do it. Recovery is available to you. And our peer also helps folks access other things they may need in the community. We have a Google Drive where we have resources for each of the communities that we're in. If they need the food bank, if they need a new pair of glasses through the Lions Club, whatever they need, our peers are there to help. And then, of course, we have our medical providers who provide medication for the treatment of addiction. We use Vivitrol, which is the injectable form of naltrexone, for treatment of opioid use disorder as well as alcohol use disorder. And we provide the prescriptions for the buprenorphine products. People know them better as Suboxone, but that's just the brand name of one version of buprenorphine, as well as other prescriptions. You know, as I said before, we encounter more than opioid use disorder. And so if someone is suffering from amphetamine use disorder and is going through withdrawal, we may provide some comfort medications for them to help in that process. And we can do the Vivitrol shots on the unit because those are non-narcotic. So our nurse can provide those. And then, of course, there is data collection that we provide for the grant to give back to SAMHSA to show, I mean, the goal is, right, that we see overdose happening less in these communities. I don't mean to sound too lofty, but our goal is to literally save lives and have people overdose less due to substance use disorder. Next slide, please. So this is a very busy slide. Up at the top here, it goes through what our mobile units do in a day, and at the bottom, it goes through what a patient sees when they come onto the unit. And I'll just quickly run through this. Our staff starts at our brick and mortar clinic where they gather the supplies they need for the day, and then they go to where the mobile unit is stored, just a little ways away, and a mile or so away from our brick and mortar in those cities. And they get ready to go. They drive to their first stop. Let's just say it's Sedgwick up in the Northeast. They arrive there, they get things set up, and they provide treatment for however many hours we're scheduled to be there, usually between 2 and 4. Then they take everything down and they go to the next stop, say Julesburg, and they provide treatment there for a couple hours, and then they take everything down, go home, put the mobile unit to bed in its storage facility, plug it in because it's a battery operated unit, and go back to the brick and mortar clinic where they drop off the urine samples, do whatever they need to do paperwork wise. What it looks like for a patient coming into our clinic is it literally is as simple as knocking on the door. We are there in the times that we say we're going to be there, and people just show up. We also have a phone number, and it is nice to schedule, but it's not necessary. We're really trying to make this as easy to access as possible for folks. So you literally knock on the mobile unit door, where you're usually met by the peer support specialist who takes care of you, gets a copy of your insurance card, gives you the paperwork that you need, and then the counselor will probably start to do an assessment with you, go through some of the data that we have to gather, and we'll let the medical provider know that you're ready. And when the medical provider is ready to see you, the nurse will take your UA, get your vital signs, set you up in the exam room with a computer, and you will talk to a medical provider. Then when you're done with the medical provider, you'll come back out and finish up whatever you need to finish up with the counselor, and the peer will get you scheduled and will call in your prescription, and you're scheduled for your next appointment and you're good to go. We're really trying to make this process as user-friendly as we can for folks. Next slide, please. So Region 1, as I said, we've got Julesburg, Sedgwick, Fort Morgan, and Sterling. We hit those. I have a 4-day work week for our folks because, as you can imagine, some travel time, it can't happen in an 8-hour workday. So we go Monday through Thursday, and we hit each of those stops. In Sterling, for example, we park right behind a sober living facility, and we have seen so many folks, we've had to add an extra day in Sterling. So we're really excited to be able to help that many people. Also in Sterling, we have a very close relationship with the CSU Extension Center out there. And in Fort Morgan, we literally park in Centennial, which is the community mental health center in that region. We park in their parking lot. So we collaborate very closely with them. If someone has mental health needs, which many, if not most of our folks do, we can give them a warm handoff to that mental health treatment as well. Next slide, please. Region 3, Arkansas Valley. We do go out to Lyman and Burlington out on the plains. We see folks there with the mobile health unit, and we go down up to Woodland Park. Up in Woodland Park, we use the parking lot of a ambulance, a specifically mental health based ambulance district, which is very exciting because it's the perfect merger of our two jobs, I guess, to serve the substance use disorder folks and the mental health folks. And then we go to Fountain and Salida and out on that with the mobile unit. Next slide, please. With our SUV serving more in the Arkansas Valley, we go up to Fairplay and Bailey, Buena Vista and Westcliff. Those are more mountainous regions. So for example, we take the SUV and we utilize as a pop-up in a local therapist's office where they have a bathroom and an office for us. In another location, we're literally using the library. So these things are how we utilize our community partners to provide services in those communities. Next slide. In Region 4A, we go out to Los Animas and La Junta. Our longest day is all the way down to Springfield, where it's about 7 hours round trip drive time. We go down to Walsenburg and Trinidad as well, where we park in the hospital parking lot, where the health department in Walsenburg has their offices. So somebody could literally go into the emergency room, the doctors could assess them as needing medication for addiction treatment and walk out and come to our unit on a Thursday and get that treatment right there. Next slide. I'm going to turn this over to Kathleen to talk to you about our West Slope regions.
Hi there, I'm Kathleen Crislip. I'm a nurse practitioner from Steamboat Springs with Front Range Clinic and part of the mobile unit team. I'll delve a little deeper into specifics with talking about a bit about what we've done with the mobile health units in Colorado's western region, and enlarge a little on how community is working together to bring substance use disorder treatment to the underserved and/or rural areas out here. So in west central Colorado on this map, the mobile unit is or will be serving the communities of Delta, Montrose, Rifle, Glenwood Springs, and Eagle County from the hub of our brick and mortar clinic in Grand Junction. Those communities are working with us to make the mobile units part of the Western Colorado treatment ecosystem. The mobile teams have been invited to participate in local treatment expansion efforts, such as the Glenwood Springs Roaring Fork Area Recovery Continuum Consortium, a coalition of medical and behavioral health providers, consultants, peer specialists, county health and human services personnel they've put together. And in that geographic area, the mobile unit's kindly been offered the chance to be one of the providers to whom the county jail will refer folks as they leave the facility. A wonderful opportunity to help serve Colorado in a broad sense, as the folks can also be offered the chance to be seen in one of the many other mobile locations around Colorado should they leave that county on release. In Rifle, we successfully sought to park the rig in a county parking lot, which is behind Garfield County Human Services, allowing us the opportunity to just guide folks straight across the parking lot to the resources they may require to help be set up for success. The rig is also near FQHC, Mountain Family Health's Integrated Care Clinic, offering primary care and behavioral health, giving the opportunity to help guide patients into the primary care that's often deferred in substance use. In Delta and Montrose counties, the mobile team is talking with the large local FQHC, which has a robust MAP program, and other community stakeholders about how mobile treatment can help support existing local services and blend with those efforts for interconnected care. Next slide. In Northwest Colorado, we use an SUV, as Donna was referring to, because driving a 34-foot rig over the mountain pass between our rural Steamboat Springs brick and mortar hub and the cities we reach is impractical, especially in winter. And as we've done in other areas, we've reached out into those communities that the mobile team will be serving and supporting to find locations to house the team as pop-up clinics because we don't have the rig. So here, as it has elsewhere, finding these pop-up spaces has provided great opportunities to begin integrating mobile treatment into those communities. For instance, the mobile team has had the great good fortune up here to be inside the North Park Medical Center 1 day per week in Walden in Jackson County, a remote but complete facility which also houses an office for Jackson County Human Services as well as an office of Mind Springs Behavioral Health. In Fraser, we flexed to find a place to pop up and are at the Community Rec Center. In Oak Creek, we started in the ice rink warming hut. In Hayden, we've been in the old Hayden Hospital on a day of the week when a local medical group is not there, and we've grown a healthy patient panel. With these Western Colorado relationships and local-centric locations like these, just as is happening elsewhere via the grant, we can foresee a bright future for the grant purpose of enhancing rural treatment while offering low barrier, high and easy access substance use disorder treatment in rural western, northwestern Colorado while supporting existing services and efforts. Next slide. Yeah, so challenges on the mobile routes abound, including the public venues that are hosting our pop-up clinics. So those venues may need to close or to use the space that we're in. And an example out here is in Rifle, where the mobile rig is via the efforts, again, community involvement of many folks in Garfield County government and public health, the Garfield County commissioners, the city government of Rifle. We're parked in a county-owned parking lot used by the adjacent fairgrounds for seasonal events. And we'll move the rig when a county event needs the space. We'll flex and find a place to move or make an opportunity for telehealth. Pop-ups can close on short notice. This is especially true in the time of COVID. And of course, our Colorado weather can always impact whether a space can even be staffed, for instance, in a snowstorm. One patient on the unit at a time. So the restrictions of social distancing and COVID precautions help to dictate the number of people who can be on the rig at any one time, as well as patient privacy concerns. And moving patients through efficiently, one at a time, so they can get on with their day can be a challenge. Symptom screening provides the same and more challenges aboard a rig as it does in a clinic, with patients and staff sometimes standing outside in the cold while screening takes place. And then masks, of course, present an issue for everyone right now, and just as much of a challenge on the mobile unit as anywhere. Next slide. So all that said, as every challenge is met, with it has come a success that makes the endeavor just one of great reward for patients and staff alike. In our outreach to community partners, the mobile unit team has certainly found some healthy partnerships waiting to be built, as Donna was referring to. As mentioned, finding a place to park the mobile clinic or to house a pop-up clinic is quite a challenge. But we've met with some great successes out here that also tick off other boxes. For instance, in Grand County, where we're driving an SUV instead of the rig, we couldn't find a spot to house a pop-up clinic in the assigned town of Granby at first, and we ended up briefly in the nearby town of Hot Sulphur Springs at the office of the Grand County Rural Health Network, which is a nonprofit organization working in partnership with health providers, businesses, and community members to help community members in this remote area with health education and navigation. And the Rural Health Network was eager to bring the program to Grand County. So their supervisor offered us a room in their office, sharing space with Grand County Rural Health Network case managers just to get the program rolling in the community. And this allowed the mobile team to start building a relationship with human services in the place where it's happening, and to learn firsthand what the mobile team might be able to offer our patients in terms of resources via that Grand County Rural Health Network. Meanwhile, we continued to search for a more permanent home back in Granby with the help of a local health navigator, and eventually found a warm welcome from the Granby Library, and by extension, the community, in a safe and locally well-known central spot. This serves as a nice example of how the challenge of searching for a pop-up clinic allowed the mobile team to begin developing a relationship, in this case with the crucially positioned Grand County Rural Health Network, which was a perfect introduction into the county. The mobile teams statewide have experienced similar successes in so many of the communities in which we're now embedded. Stigma can, of course, be a major obstacle in establishing in a community. Here, by embedding in an already trusted location like the North Park Medical Center in remote Jackson County, with the medical center's local centric service and family doc who's a multi-generation Jackson County resident, the mobile team is in a position and a place where our patients can be somewhat shielded in that they can come into the clinic through a side door if they like, but they can also start to feel that this is just another facet of healthcare inside their own local medical office. The same is true of being embedded within a local clinic in Hayden. An inroad toward decreasing stigma is the community and our patients seeing substance use disorder treatment as, again, just another facet of healthcare. Some of the communities that we're in lack pharmacies. I'll use North Park's remote Weldon again as an example. The nearest retail pharmacies to this community of less than 700 folks are an hour to an hour and a half away, depending on weather, in either Laramie, Wyoming, or Steamboat Springs, sometimes over treacherous winter roads. So through outreach in Steamboat, we discovered a partner with Memorial Regional Health Steamboat Pharmacy, and for 3 weeks now, that pharmacy has successfully delivered to our first patient in Walden. The pharmacy has driven an hour each way to deliver this one patient's prescription, and that may become sustainable as the pharmacy's ability to deliver is now known to the medical center in which the mobile pop-up clinic is embedded. into the Mine Springs Behavioral Health Office, next to the mobiles office inside that clinic. And so it's becoming known that that pharmacy is available for deliveries to remote Jackson County for other needs and from other providers. There's a small fee for this delivery, but because of the relationships that we've been able to develop via the search for these pop-up locations, we know who we can ask for help, brainstorming funding for that. For instance, among its many other services, the Grand County Rural Health Network finds innovative ways to aid community members with transportation and other health costs and challenges. And ultimately, the patient in this remote mountain community is receiving treatment and having medication delivered, rain, snow, sleet, or forest fires. And I find this a shining example of the larger community across 3 rural counties in conjunction with the state's Office of Behavioral Health and with the grants coming together to serve patients in our frontier in a frontier area, really meeting the goal on every level. I'll turn it back to Donna to talk a bit about telehealth and behavioral health and wrap us up.
Yeah, and then we can answer some questions after we're done. Thank you, Kathleen. That was fantastically explaining that some of the things we've encountered, right? So one of the biggest, I try to look for silver linings, and one of the biggest silver linings around this whole COVID business is that we've been providing telehealth services prior to COVID, but they just weren't getting paid for by Medicaid. And I saw in one of the questions they asked if we take Medicaid, yet about 85% of our patient population does have Medicaid insurance, and we certainly do take Medicaid for both medical and behavioral health services. So our behavioral health services being able to having more access and just folks being more used to them. We have noticed that people in the beginning of COVID were not so excited about telehealth services, and they have come to love it. For example, I can now do group counseling with someone out of the privacy of their own home instead of asking them to get a sitter for their kids and drive across town. So it's just a huge benefit to us to be able to finally provide group counseling and individual therapy services over telehealth and have that be accepted culturally as well as getting paid for. And I do want to open it up to questions because I know that we have a few and we've got 10 minutes left. Do you read them, Matt? Is that how we do this? And then we all just kind of answer them?
I'm supposed to read them, but Dr. Dubin and Donna are just always so on top of things that they answered most of the questions in the chat. So I'm going to pick a couple of them so you guys can speak on them a little bit. Since you're over here making my job a little bit too easy. It's not usually what happens, right, guys? So one of the questions, I think it's a really good one, is are you tracking your mobile relapse, overdose, and death rates? And if yes, how do they compare to the traditional brick and mortar services?
If you don't mind, I'll take that one, or you guys can add in there. Good question, because I think what the assumption is there in that question is that isn't this inherently more risky? And I think that you're correct. I think it does seem like it's inherently, there's a higher risk. So what we try to do is we try to create more continuity between our medical providers and the patients they see in the mobile health units. The metrics we use as far as for overdose and diversion and people not making progress in recovery, we are applying to the mobile units as well. And we try to look at those really every year to see how we can improve things and how we can improve patient retention, how we can improve more comprehensive treatment. But I think you're correct. I think the mobile units inherently have a higher risk. And it really gets into that kind of whole harm reduction kind of conversation of in some of these communities that really had nothing versus now having something. And then ideally the goal, and then Donna, correct me if I'm wrong, is that over the course of a couple, 3 years, the point is to try to create these comprehensive treatment or capacities in these communities. So whether it's over time educating this primary care doctor or enlisting this counseling center or talking to someone like Dr. Barnes and Steamboat and enlisting them to be part of a treatment program or a community resource that will ideally lower that risk and move from more of a harm reduction approach to more of a healing and therapeutic approach. I hope that answers that to an extent.
Yeah, and just to add on to that, yes, we are tracking that. We're tracking that through the Office of Behavioral Health. So I don't have that data right now, but it is being tracked through the grant process.
Thank you. One of the questions is, can you provide a website to direct clients to the days and times? And I will put that in the chat. And then next question is, do you provide the group teletherapy outside of your normal service areas?
I'm not sure what that means. I mean, we provide group teletherapy throughout the state, like literally anybody anywhere can access any of our groups. I'm not sure I'm getting at that question.
Is the question like, if you're not in one of the designated sites or brick and mortar clinics, like could someone just go to like a parking lot in some other town and just kind of dial in? I think, and Donna, correct me if I'm wrong, the idea is that you'd have to be established with the clinic to do that. And we'd probably try to steer you towards those areas. But at the same time, if someone's established and they don't, and they're in a town that doesn't have a MHU stop, Donna, they could still come, they can come from wherever, as long as they're established with us, I think.
Yeah, we have 7 licenses with the Office of Behavioral Health out of our brick and mortar clinics. And from there, they can access telehealth therapy. So they would have to, do the paperwork somewhere, but from there they could be at their home ongoing accessing telehealth therapy.
Great. Next question is, what do you see as the future of the mobile health units, and how will these look in 5 years?
That is a great question. We did not talk so much about sustainability because, as I said, this is grant funded, right? So grants go away eventually, although we did just get awarded another 2 years. So we are grant funded until September of 2022, which is great. But after that, we have made an agreement with the Office of Behavioral Health to continue the services, and we have no intention of stopping. We will own the mobile health units at that point, and we will continue to treat folks. We may decide to go to different places depending on what we discover in the next 2 years. For example, Fort Morgan in the Northeast was not one of the originally mandated communities, but we learned that they really wanted us there, so we're going there now, kind of thing. So where exactly we go could shift, but our intention is to continue to provide services.
Our intention also, Donna, I think, is to be obsolete. I mean, the idea that the grant is trying to push us to create these resources in the communities as well. So the idea that as we move forward, I think how we would define success, and I think how OBH might define success, is that all of a sudden we had a busy RV for a year, 2, 3, and then we were able to create a community, a resource, basically a network of resources in a place that they don't need us anymore, that they can create that continuity. Until we get there, we're going to just keep filling in the holes. But I think, I think that's part of the push too.
Thank you for bringing that up, because that is super important. A mobile unit is never meant to be sustained forever and ever. And this is why we're parking in the Centennial parking lot in the Northeast. Our idea is to find the people who need the treatment and haven't been getting it, get them started on treatment, and then hand them off to the community partners that are continuing to provide that treatment. So it's a little bit of both. But yeah, the mobile unit is not meant to be forever and ever.
Thank you. And I think we probably have time for 1 or 2 more questions. So one of the questions that was answered, and I just want to note, there were a lot of questions asked and a lot of them were answered. So please make sure to go into the Q&A and click on the answered button to see all of the various questions and answers that came up, not only for this presentation, but the previous ones as well. But one of the really good questions I thought was, how does the SUV mobile unit differ from the RV units in terms of setup, and what are they equipped with?
Kathleen, do you want to take that one?
Essentially the same. Yeah, it's the same equipment that the RVs have on it, but we bring it with us in rolling suitcases and set up and break down and bring it back home with us.
It's telehealth. The medical meetings are telehealth, so that can be done we've got our go bag.
And then I'll ask one more. How many clients on average visit the mobile unit on a daily basis? What does the volume look like?
So yeah, it really depends on the community. I would say on average, we're looking at between 8 and 15 folks at each site daily. We have gone up to as high as 24 was our largest day. And I have to say my staff was a little bit overwhelmed with that, but it can be done. But on average, in some communities, we're just seeing a small handful of folks. But on average, I would say between 8 and 15 a day at each site.
And I lied, I'm gonna ask one more because I think this is a good thing to ask. In your opinion, in your experience, what makes the mobile units stand out differently from other types of services, and how are these unique in offering services to underrepresented communities and rural communities? Really speaking to the value of this project.
Donna, can I speak? I'll take the first 5 seconds, I'll give it to you. I just wanted to throw out there that one of our missions at Front Range Clinic, and one of the reasons I think that we've been able to create good partnerships with this, is that what makes, I think, our approach to this a bit unique is that we are a medical clinic first, and the behavioral component is secondary. I'm not trivializing the importance and the utility of the behavioral component. The difference is that a lot of substance use disorder clinics out there kind of start more on the behavioral side and kind of plug in the ancillary medical piece. I think that we are just very well positioned to create that medical intervention or leveling of the playing field opportunity first, and then to plug in all of these healing modalities that include the behavioral components. I think that's a little unique with these mobile units compared to some of these other ones. And I think that we have access to Medicaid, so that's going to hit a lot of these underserved communities. That'd be my answer to that, Donna.
Yeah, I think so as well. I think that was very well said. I mean, we're just, trying to reach those folks who haven't had access for whatever reason. And, another piece of what we're trying to do out in these rural communities is really address the stigma. So we've heard from a lot of our rural communities that methamphetamine, gosh, it never went away, and it seems to be back in full force, and alcohol are huge issues. And it's hard for people to go seek treatment for that when everyone knows what your car looks like. And if you're parked outside of the local addiction center, everybody knows exactly what you're doing in there. And so our hope is to reduce that stigma. You notice on the mobile unit, it did not say addiction treatment, get your mat here. It's a very nondescript. So they could be coming onto our mobile unit for a flu shot, or a mammogram, or addiction treatment. And it doesn't say on the outside what it is. So we're hoping to reduce some stigma by leveling the playing field for addiction treatment access.
Thank you, guys. There is one last question in the chat, but I'll go ahead and let Dr. Dubin answer that with his little fingers there. Go ahead and type in the answer. We do need to move on to our next group. But thank you for your time. Thank you for sharing. And I did put all of the contact information in the chat. So if anybody has any further questions about the mobile unit project, please feel free to reach out. Thank you.